اتفضل يا فندم.
Good afternoon, ladies and gentlemen. It's my honor and privilege to be a chairperson for this very important session. And I welcome you to our 7th Ain Shams University International Clinical Oncology Conference. And I hope in those 3 days to fulfill all of the updates in the oncology practice. Ain Shams had the honor and privilege to host the first time a session for the physics 2 years ago, and we are continuing with 2 stars of the physics who are the most important pillar in the radiotherapy treatment and the oncology treatment in Egypt. And I would first like to thank, after thanking the organizing committee for such a great effort, thank Iris for this very, very talented virtual different experience, as you mentioned it. It's really a changing practice from asking who are attending to seeing how many participants online. And those almost 51 who are participating with us now, we are honored to have you with the Ain Shams. And for the advances of medical physics in cancer treatment, I would start with all of my honor with Professor Dr. Amin Sayed, Professor of Physics, Medical Physics, Ain Shams University, and he will speak with us about the laser light in cancer treatment. Please do.
Okay. This afternoon, I am going to talk about laser light in cancer therapy. This is a preliminary presentation to let us know about laser light and what are its uses in cancer therapy. The word laser is an acronym of light amplification stimulated emission of radiation. We have to keep in mind that laser light is non-ionizing radiation. Hence, laser therapy is not considered as radiotherapy. Laser light has the following properties. It is a monochromatic, directional, and coherent light. Laser light is different from regular light, which is coming from the sun or from a bulb. Ordinary light has many wavelengths and multi-directional and incoherent, while laser light is monochromatic, directional, and coherent. The meaning of monochromatic light, such as laser, is that it has one color, one wavelength, and one frequency. In contrast, ordinary white light is a combination of many colors or wavelengths. Laser emit light that is highly directional. This means that laser light is emitted in a relatively narrow beam in a specific direction, while ordinary light, such as light from the bulb, is emitted in many directions away from the source. The light from laser is said to be coherent, which means that the wavelengths of laser light are in phase in space and time, while ordinary light can be a mixture of many wavelengths. These 3 properties of laser light make it more effective and hazardous than ordinary light. Laser light can deposit a lot of energy within a very small area. There are some physical phenomena lead to the production of laser. These phenomena are absorption, spontaneous emission, stimulated emission, and population inversion. When energy is absorbed by an atom, the electrons are excited into vacant energy shells. The atom decay from high energy level to a lower energy level through emission of photon with energy equals the energy difference between the two levels. Atoms in upper energy level can be triggered or stimulated in phase by an incoming photon of a specific energy. When a large number of electrons raised into upper energy level, this condition is called population inversion. In order to obtain coherent light from stimulated emission, two conditions must be satisfied. The first condition is that the atom must be excited to the higher energy state. This means that an inverted population is needed. In inverted population, more atoms are in the upper state than in the lower one, so that emission of photons will be dominant or will dominate over absorption. The higher state must be a metastable state. A metastable is a state in which electrons remain longer than usual in that state, so that the transition to the lower state occurs by stimulated emission rather than spontaneous. According to those conditions, the stimulated photons have the following unique properties. They are in phase with incident photon. They have the same wavelength as the incident photon, and they travel in the same direction as incident photon. According to the above described properties of laser light, laser therapy uses light to treat cancer cells because it is concentrated, so it makes a very powerful and precise tool. In laser therapy of cancer, laser can cut a very tiny area, less than the width of the finest thread. They can remove very small cancers without harming nearby tissues. Lasers are used to put heat on tumors to shrink them. Lasers are sometimes used to activate, or it can be used with drugs that are activated by laser light to kill cancer cells. Laser beams can be bent by going through tubes for hard to reach places. Laser can be used with microscopes to let healthcare providers see the site being treated. In surgery, laser surgery is a type of surgery that uses laser beams instead of tools such as scalpels. There are several types of lasers. Each is used to do certain things during surgery. Laser light can be delivered either continuously or as pulses. It can be used with fiber optics to treat areas of the body that are often hard to reach. These are some of the lasers. In the following slides, we will show some of the lasers used for cancer treatment. Carbon dioxide laser can remove a very can remove a very thin layers of tissue from the surface of the skin without removing the deeper layers. So it may be used to remove skin cancer and some precancerous cells. Neodymium, yttrium, aluminum, garnet laser, which is called NDYAG laser, can get deeper into tissue. They can cause blood to clot quickly. The laser light can be carried through fiber optics to reach internal parts of the body. For example, the NDYAG laser can be used to treat throat cancer. Laser-induced interstitial thermotherapy, LITT, uses laser to heat certain parts of the body. The lasers are directed to treat areas within body tissues that are near a tumor. The heat from the laser tissue, raises the temperature of the tumor that shrinks, damage, or kill the cancer cells. Argon laser pass only through outer layer of tissue, such as skin. Argon laser can be used to treat skin problems or in the eye surgery. Photodynamic therapy uses argon laser light to activate chemicals in the cancer cells. Photodynamic therapy can destroy just cancer cells and leave most healthy cells alone. It is used to treat certain cancer tumors. Photodynamic therapy is also called photoradiation therapy or photochemotherapy. It uses combination of light sources and a photosensitizing medicine activated by light. The medicine is often injected into the blood. It collects more in cancer cells than in normal tissue. When the laser light is focused directly on the tumor, the cancer cells absorbs the light. A chemical reaction occurs that kills the cancer cells. In photodynamic therapy, photodynamic therapy has been approved by the FDA to treat certain types of cancers that are found just under the skin or in the lining of certain organs. This is because photodynamic therapy can only pass through limited tissue depths. Cancer types that may be treated with photodynamic therapy are cancer of the esophagus, non-small cell lung cancer, and precancerous skin lesions like actinic keratosis. Photodynamic therapy may have fewer side effects than other treatments. It can also be used again and again in the same site if is needed. Major side effects of photodynamic therapy are sensitivity to light and swelling as a treatment site. Both the eyes and skin are affected by that light. This may last up to 3 months after treatment. Swelling can cause pain. Swelling also may make it hard to swallow or breathe, depending on the location of treatment. Other side effects of photodynamic therapy may occur. They depend on the area being treated amount of damage may also occur in healthy tissue. As each person's health profile and diagnosis are different, so his or her reaction to treatment may differ. Side effects may severe, mild, or absent. Lasers are used in surgery for a certain types of cancer because these often have a special requirement that only lasers can meet. For instance, the laser can reach a hard to treat area, apply heat, or cut only very small area. They may be used for vocal cords, esophagus, cervix, skin, lung, vagina, and vulva. Laser surgery is also used for palliative surgery in people with cancer. An example of this type of surgery may involve removing a growth that is making it hard for a person to eat. Lasers are more precise and exact than blades. For instance, the tissue near laser cut or near the incision is not affected since there is little contact with skin or other tissue. The heat produced by laser helps sterilizing the edge of the body tissue that it is cutting, reducing the risk of infection. Since laser heat seals blood vessels, there is also less bleeding, swelling, pain, or scarring. Operating time with laser surgery is shorter. Laser surgery may mean less cutting and damage to healthy tissue. It can be less invasive. For example, with fiber optics, laser light can be directed to parts of the body through very small cuts without having to make a large incision. More procedures may be done in outpatient settings. Healing time is often shorter. On the other hand, the laser treatment has some limitation. For example, most of the medical staff are not trained to use laser. Laser equipment costs a lot of money and it is bulky compared with usual surgical tools. But advances in technology are slowly helping reducing their cost and size.
We need to conclude very soon.
Precautions must be followed in the operating room when lasers are used. For example, the entire surgical team and patient must wear eye protection. The effect of some laser treatments may not last long, so they might need to be repeated. And sometimes the laser cannot remove a lot of the tumor in one treatment, so treatments may need to be repeated. Thank you very much.
Thank you, sir. It was an elegant, as usual, and conclusive about all the items we are dealing now with the laser therapy. And if I'm online right now, I would be glad to introduce my dear friend and eminent colleague for all of those who are working in the radiotherapy field all over Egypt and in the Arab world, Professor Dr. Khalid Al-Shahat. He is the acting chief of the Clinical Oncology Department at Al-Azhar University, Clinical Oncology Department. We're going to talk about the targeted radiotherapy techniques. Dr. Khalid, please join us.
Assalamu alaikum. Good evening. It is a certain pleasure to meet all, and today I will speak to you a little bit about target or adaptive radiotherapy and the image-guided strategy for radiation treatments. Here is a brief outline of what I would like to go over this evening. We certainly have a good group of speakers, as usual in university conference, and that would fill, but I will like to go over some basic concept as well as discuss some of the technology that are out there, like RGRT, and I will begin with some big picture concept for radiotherapy. Big picture concept about radiotherapy is the principle of radiation therapy, that is the ionizing radiation has penetrated power and potential to destroy cell, both normal and malignant. Thus, is the therapeutic ratio in which outcome depended on the ratio to tumor of the tumor control versus tissue toxicity. I will try to get some across very early our discussions, and in so doing to begin understand, we take careful planning to try to achieve maximum tumor cell kill while also sparing normal tissue in hope to preserve functions for the organs around the tumor treatment. There are a host of factors that impact the therapeutic ratio, certainly about our ability to correctly identify tumor versus normal tissue. The first steps in radiotherapy after decision, this patient will take radiotherapy, tumor delineation. CT with the using different modalities with the CT for the treatment, PET, CT, MRI, SPECT, and the different modalities to be good, accurate, to be sharp. This is and the sharp definitions, the targets or non-targets. Accurate deliver needed some visualization and some guidance for verification the target positions, and after that we discussing some about the fractionated and the total dose and the dose rates, radiation modifiers, and the location for the patient in other sites. Precision and accuracy, I am sure you are well familiar with the concept, with this concept of the precision and accuracy in the treatment, but it is to be sure the high precision, low accuracy, and the high accuracy, low precision, you need, and me and all, you need precise and accuracy for the treatment on the radiotherapy. The term of target definitions, we are all familiar for this. For gross target volumes, the clinical target volumes, we assume and we got elective identify disease extended and both cross and subclinical disease. Planning a target volume define our level of uncertainty in the setup and deliver, and just to assume we know our precisions and accuracy. ICRU 62 and 83 defines a couple of new terms which do not change our definition of the BTV, but help us to generate it. It's the internal margins, variation in the size and shape and the position of the CTV in the reference to the patient coordinated system using anatomical reference point, and internal target volumes. It's described as CTV plus internal margins, and after that we'll adding the addition setup margins that is take into account uncertainty in the position relative to the treatment allowed us to the familiated a better BTV. The term of the so why to margin matters. It is come down to the, you can see small margin reductions decrease the volume of the range by half of the volume initially. How we do that? The real cannot do much with the GTV and CTV as those are defined by tumor on our clinical judgment and radiological colleagues the best to define them. However, BTV is our control, so on the spectrum of the patient setup and the treatment deliver options, skin marker, or weekly portal image necessary to the larger BTV margin. We then have increased level of sophistications in the setup and deliver that yield smaller BTV margin to reduction. The BTV margin needed highly accuracy and precision of the target definitions and treatment to be sure this is target is including beam on during all time of the beam. All in all, what we are really looking for this type guidance is to have the best defined tumors and normal tissue and how to accurately align the patient and treatment them with each fractions allowed us to deal with the intrafraction motions. In the term of intrafraction motions, these are three main approaches. Enlarge BTV margin, prevent motions, is stop the motion of the patient. It's possible in some institute, but not particular comfortable. Tracking motions as a guide for treatment tumors, and tumors stay all over the treatment in the beam. It's like this system, it's an image-guided radio. Definitions, image-guided radiation therapy. It has two parts. Use modern imaging technology for defined tumors and normal structures. Use the modern imaging techniques to accurately with the precise delivery of the treatment. Adaptive radiotherapy or targeted radiotherapy, modulations of the therapy to compensate for the changed tumor tissue anatomy during this course of the treatment. All sessions, during all sessions, not the white session, not first, second, that during all session to be reductions, the dose, the toxicity of the organ at risk, and maximize tumor killing effects. Some definitions for IGRT, like 6 Ds of IGRT, board definition, detections and the diagnosis, delineation of the target and organ at risk, determined for biological attribute, dose distribution design, dose delivery assurance, screen treatment response through the imaging. IGRT tools, we see many tools using in the IGRT treatment planning, PET-CT, MRI, CT, 4D CT for control the imaging motion of the patient, treatment delivered like the electromagnetic transporter, Calypso, ultrasound, video, planning 2D, volumetric 3D, gating, and immobilizations. 4D CT technology, that is, I am most familiar with the including, like Philips on the left, which we had one, in my hospital, and GE for scanning. The first CT allowed for respiratory gating to see tumor and the tissue motion index to the respiratory cycle and generate 4D dimensions of the time to 3D CT information. Maybe in somewhere some CT using deviceless 4D, and with another using like my hospital, like by using it. Electromagnetic transporters such as with Calypso technology allow to the image guidance. This has permanent has been using prostate cancer treatment. Special phodicials or beacons are implemented in the prostate, and then in array to receive can detect signals from this beacon and to be sharp with the infrared camera in the room are able to index the positions of to the treatment table, because this separated from the neck and prostate position can be tracked throughout the treatment delivery. There are different types of ultrasound-based IGRT solutions, including PET-CAM, sonar array from Varian, and I-beam from CMS. Three-dimensional information is translated from the ultrasound to the LINAC for improved patient setup. Video-based IGRT is shown here from Vision RT. Infrared camera detect the surface anatomy at the time of the simulation, and the treatment allowed a topographic alignment of the patient. This shows breast cancer patients, as the image we can show. Cancer patient with simulated and the treatment position overlay allowed to the therapist to align the patient more easy and good reducibility for the treatment. And in the same way, at the time, I will introduce onboard or UBI from Variants, and maybe in the same from Electa, that I am most familiar with, which can provide 2D and 3D image guided. That's found in machines like Vital, TrueBeams, and machine Versa HD and other. And I use pulsing in the different hospital here in Egypt. Others with a planner 4T. This is a 2D IGRT, maybe using as a CyberKnife, Accuray, Electa Synergy, or Electa Versa HD, Novalis, Siemens, that's used before, Variant Rheology, and now is in the same model of machines, maybe in advanced machine like Vital Beam, TrueBeams, IX. The features of the Novalis orthogonal X-rays, image-guided patient alignment. It's to be exact, like to be sure, this is a part of the digital reconstruction radiographic bone anatomy, and in different show in like in 3 and 4 alignment overlay, and in 2 and part 4 show post alignment showing excellent matching to be to starting is good with the marker with the imaging implemented in the patient to good treatment of the there are once again different options for volumetric 3D image guided. Siemens illustrated Siemens CT vision, CT on the exact linear accelerator machines. That's the old variants. It's cone beam, both cone beam scanners, and Novalis, and Artist, and tomotherapy, high arts, Electa Synergy, and Versa, and Access in the same volumetric, have the same options as the volumetric 3D image reducer. The mean megavolt image technology out of there, including M-Vision, like the Siemens, and tomotherapy now is in the marketing. I can see in this slides as the planning of the IGT content, closing the loop for the methods of the corrections, residual errors for the image-guided correction technology in the prostates. Like what started with skin markers, weekly imaging, daily imaging, daily ultrasound. We see some reductions of the errors due to good, accurate, and by using cone beam with the fiducials markers outside. And in the other way, comparisons the residual errors for the different image-guided correction in the treatment, like in other tumor site, like lung tumors. Tumor motion and tracking have some, this is a big problem to motion control for tumors, to be sharp with these tumors in the same positions, like the reference T, we use different modalities. We allow it to slide to regarding BTV margins, and that is more sophisticated guidance. So we now spend the next several slides discuss tumor motion and the trackal options, which are boarded groups into those that prevent motions and those tracking motions.
To dear colleagues of IRIS, I think we should conclude right now with Professor Dr. Khaled.
Exit track X-ray, 6 adaptive tracking variant or Novalis, 4D, CT, and respiratory. Immobilizations, they are few adaptive for the targets and the reduction of the target after that. Spinal cord and brainstem, and as well as all canals. Some pilot study, like this study, is involved 4 patients, is PET CT and scan. After that, we'll do with different modalities and the reductions of target volumes, and we can adaptive for the patient reduction, dose escalation, or decrease the normal tissue complication probability. Motion analysis for the 100 mediastinal lymph node nodes, potential and the treatment and the planning and the adaptive strategy. You can see different adaptive treatment challenge, how to handling the increasing workload, how to register the anatomical data, and twin and it triplan, ideal real-time adaptive guided. Evaluation of adaptive radiotherapy. You can see image days planning, and after that we'll treat it. Like an image guided radiotherapy, not the same. Image guided days, planning patient day, image guided again, imaging patient and degree treatment, or in some way, image guided offline adaptive or online to be continuing with the treatment. Thank you.
Thank you, Dr. Khaled, for this elegant presentation as usual, which concluded every aspect of the targeted radiotherapy techniques. And I know we are lagging beyond the schedule, so I move quickly, very fastly, for my colleagues in IRIS to introduce the next session. Thank you so much.